Okay, let's just start the ball rolling for lung ultrasound, because this is where I work at the moment. This is something I'm affiliated with, the WIN-Focus Interactive Network focus on the World Interactive Network focus on critical ultrasound. A bit of introduction on how on ultrasound in intensive care. This was actually a 1993 publication by Daniel Lichtenstein. It was a study of 150 consecutive patients. And in the 1993 study, this was the first 5 documentations of the use of ultrasound on the lung. Okay, and we have progressed until this was a bit more recent, 2012. This is a WIN-Focus international evidence-based recommendations for point-of-care ultrasound. Before this, about the 5 to 10 years before 2012, I think there were numerous publications, particularly in intensive care as well as emergency medical literature with regards to lung ultrasound. There's also this concept of the ABCD approach of point-of-care ultrasound, published by Luca Neri and Ingrid Costotti and Daniel Lichtenstein as well. Okay, a bit of point-of-care ultrasound definition. It's defined as ultrasound brought to the patient and performed by provider in real time, and can be obtained immediately, and clinician can use real-time dynamic images. So my take on it is that point-of-care ultrasound will involve 3 characteristics, which is actually point of care or bedside, wherever bedside, the definition can be, ICU ward, even pre-hospital, so on and so forth, by a clinician, not by a diagnostician, because the clinician will interpret immediately the findings of the point-of-care ultrasound. And the other one is actually POCUS, because we POCUS providers or POCUS users are not there to function as a sonographer or radiologist, but to function as a clinician. So our intention is not to do a complete full examination, but only certain examinations and very focused. This was a New England Journal of publication list. Okay, you could see for critical care medicine, there's only procedure guidance, primary assessment, is lung, as well as focused echocardiography. But how have we progressed? This was a 2020 publication, and I'm proud to say I've got 2 Malaysian colleagues, Mahada Abu Wahab, the emergency head of service, KKM, as well as Dr. Adi West, Dr. Adi here down here, was also part of this international expert consensus of how to use point-of-care ultrasound for COVID. There's a long list here. I'm not going to go into great detail, but technically we can use it for respiratory failure, which I will of course allude to in a short while. There are things that, for example, Nafis mentioned in the first few talks that, when we are all done up, it's very difficult to put the stethoscope on, particularly when we're using the PAPR. Fluid assessment will be touched upon later by my subsequent speakers, and also, of course, I think there's also a talk on ultrasound-guided vascular access. So there's actually quite a bit that we can do with ultrasound, but I'm just going to concentrate on lung ultrasound. So just for since majority of us are anesthesia, I'm just going to highlight this was actually the first 2011 article in anesthesiology on the use of lung ultrasound, in perioperative lung ultrasound to diagnose pneumothorax. So way back in 2011 was the first one. And also this in 2012, there was a BGA article on the diagnosis of lung consolidation in a peri-op setting. Okay, how to do it. So this is, I think, the important bit. Hopefully, most of you will have something to take home with. We can use any probe. Most of the time, we will use low-frequency curvilinear. We can use even a linear, but maybe a linear would be mainly for looking at the pleura rather than anything else. Of course, in the literature, all this have been used, but I think for simplicity's sake, we're just going to concentrate on the curvilinear. Okay, and how we do this, we kind of use a orientation, 2 probe orientations, the longitudinal scans where you Keflet and Cordet orientations, and transverse where you put the probe across right or left or right, depending on how you see it. The topography, this is important because there are some scores that you can do the lung ultrasound score, because and when you report this, this is the anterior axillary line, posterior axillary line, and this is how you divide the zone, lung ultrasound zone 1, 2, 3, 4, 5, 6. In most situations, this may be difficult in ventilated patients, but you may want to turn them, or you can dig into the ICU bed, and you may be able to scan probably the lateral bits of the zone 5 and 6. Okay, exam technique. When we screen, I would like to advocate that we do use the anterior as well as lateral. Let's look at what is normal first. So when we put it in the longitudinal view, this is what you're going to see. Can you see the lung moving? So that is actually sliding sign. And that is actually the pleural line moving. So that is actually where the visceral and parietal pleura is located. And next to it is actually the rib shadows. And this is what you call the A lines, the reverberations of the A lines underneath the pleural, the actual pleural line. It's actually an artifact. It's not there. Of course, it is not an actual image. It's more it is an artifact of the ultrasound image. And when you put on the lateral component, it's important to actually appreciate the abdominal organs. So this is actually a fast view focus assessment with sonography for trauma. So it's important to know to note where is the liver as well as the kidney. Okay, so this is where you appreciate, this is the Morrison's pouch or the hepatorenal recess. This is important because in the event of you see something like this, in the hepatized lung, it may mimic actually a liver. So, and then this is a diaphragm. And can you see this sliding on top? This is actually some sliding sign, and some would say this is a curtain sign. So this, when you see this, you will know that you are dealing with actually a normal lung above the diaphragm. Okay, on the left side, it's a bit more, you need to probe more posteriorly, and this is what you're going to see. The spleen, the kidney, this is a lienorenal, the splenorenal recess, the diaphragm. Of course, it's not, sometimes it's quite difficult to actually see the diaphragm. And again, this is a sliding sign. And when you see this, you know that you're not dealing with a pneumothorax, you're not dealing with an effusion. It is normal lung. Okay, what about abnormal? Let's see some of the abnormal findings. So in terms of pathology, we can actually clearly define this for pathology. Of course, it's going to be mix and match depending on the actual disease, so the actual pathology. But in terms of sonopathology, these are the four main conditions that you will pick up. First, effusion. Because effusion, the content of effusion is, of course, water, whether it's exudate or transudate, but this is what you're going to see. Can you see that? That is an echogenicity, which is consistent with fluid. And of course, in certain conditions, for example, fluid will be blood in trauma until proven otherwise. So this is actually the spleen, the kidney, and you can see the fluid here. It is a pleural effusion. Okay, in this particular one, you can see the effusion, but can you see this is actually a collapsed lung? And in the actual effusion itself. So this is a diaphragm. Okay, interesting, important definition is actually the concept of interstitial syndrome, which is actually, it is actually a sonographic entity. It's actually because of interlobar septal thickening. When there's more lung water, there will be certain characteristics on the lung ultrasound. So, okay, you will see B lines, a lot of B lines as compared to A lines, which is dry. So, of course, the classic appearance of B line will be, particularly if it's generalized, it's going to be pulmonary edema, but it can be other conditions as well. I'm not going to go into great detail of how it is the pathophysiology of how is it generated images, but go backwards. Sorry about this. Okay, It can be pulmonary edema, pneumonia, particularly in the early, before the hepatization, contusion, as well as ARDS. ARDS is usually a combination of a bit of both, effusion, B lines, a bit of consolidation in the lungs. Okay, so this is pulmonary edema. So when you have florid B lines, and when there's numerous B lines, the pulmonary edema is actually worst off. And if proper treatment, for example, and a non-invasive as well as diuretics, you can see that the B lines in terms of numbers will go down, as well as the diameter of the B lines will definitely decrease. Lung ultrasound can be used to predict therapeutic success. Okay, this is what you will see in pulmonary edema in most situations. You will see a bit of B lines, as well as effusion down in the bases. Okay, this is pneumonia. Okay, pneumonia, so somewhere between B lines and hepatization, which I'll show you shortly, there'll be a lot more. So technically, in what happens in the lung parenchyma itself, there'll be a bit more of transudate or exudate in the alveoli, so a bit more of solidification of the lung parenchyma, and this is what you're going to see, a bit more noise, echogenic signal coming from the lung down below. There are a few signs involved, but I won't go into great detail as this is more basic. When in the other extreme, you will see this. This is actually what looks like a liver, but it's actually the lung, and you can see that actually looks very solid, and this is what we call hepatized lung. But the interesting bit is can you see this? That is a dynamic bronchogram. Can you see that during inspiration, or whether it's positive or negative, you can see that there's actually expansion of the bronchus. Okay, this is what we call bronchogram. It can be static and dynamic, and when we describe it in chest radiograph, but this is also something that we can see in lung ultrasound. Something interesting when you do this, you can differentiate between true consolidation as compared to atelectasis. Consolidation will have some degree of bronchograms, as shown here, whereas atelectasis, for example, in massive pleural effusion, you won't see the evidence of bronchogram. Okay. Okay, so this is something interesting. Of course, when you do chest X-ray, sometimes it can be a bit confusing which one would benefit from a chest drainage. You think it's consolidation, effusion. Of course, you want to do your percussion and so on. But of course, this is in intensive care, and particularly in the COVID environment, you don't want to do all that. So when you put lung ultrasound, you can definitely benefit. This will improve patients' overall respiratory function. Whereas doing a chest drainage or doing thoracocentesis might actually be harmful to the patient. This is something interesting that I find very useful if you are dealing with tachypneic or patient in respiratory distress. Okay, I'm not going to go into great detail of diagnosing pneumothorax with ultrasound, because there's actually a short presentation afterwards. But technically, this is important bit, the lung point, if you're not going to listen to my next half talk. So if you put your probe down here below, so that is going to just follow my cursor. There's no lung sliding, no sliding. When you put the probe here, when there's actually the junction between the pneumothorax itself as well as the lung, this is what you're going to get, lung point. Can you see part of it? There is no sliding, and this is sliding. So when you have that, it's 100% pneumothorax. And the more posterior it is, or the more the bigger that the pneumothorax is. Okay, and this is also important, lung pulse, because if you have a significant pneumothorax, you won't be able to see the cardiac pulsation being transmitted to the anterior chest wall. Okay, this is just description by Lichtenstein about the different profiles. A profiles mean usually technically they have a dry lung, and when you have B profile, it refers. I'm going to just play that it refers to a slightly wetter lung, and of course, when you have one side A and one side B, you call able. Okay. There's also this protocol published by Liechtenstein. It's a blue protocol. Okay, you can diagnose most condition except for probably COAD or asthma, which requires a lot more other examination. But pneumodema, pneumonia, pneumothorax. With pulmonary embolism, I know there was one or two presentation about using it with echo and things like that. But one thing that you could also look for is actually compression sonography is DVT in the big veins. Okay, this is something interesting. How are we? What about lung ultrasound in COVID pneumonia? So this is just something very unique to COVID pneumonia. Is actually what we call subpleural consolidation and it's irregular A lines, irregular pleural lines. So particularly when we are screening, I think this is something useful. If you might have difficult access to chest radiograph or even difficult access to CT scan. This is something that you may want to consider. Of course, may not be truly helpful in the ICU environment, but probably in outside, in ED, or particularly in the wards where you are screening for the patients. This is a helpful finding on lung ultrasound. Just to revisit this again, the multi-organ thing. Okay, in the article, it is mentioned about this, how we can use lung ultrasound to differentiate between the L phenotype and the H phenotype. Okay, just to remind people again, the L phenotype, when you have basically the lung compliance is good, so you don't need that much. So you can see that there is only a lot of B lines in this particular 6 on each side, the 6 topograph of the lung, and then there's a little bit of B lines here and there with subpleural consolidation, but compared to the H phenotype where the lung compliance have dropped, the patient may usually require, the patients will require high pressures to ventilate. You can see a lot more of these B lines, and you can see a lot more of the consolidation consolidation on lung ultrasound, and this can actually determine whether we want to put high PEEP or low PEEP, or whether for example, pronation would benefit for this patient. So something that may be useful in the ICU environment. Okay, I'm not going to go into great detail because I've got probably 20 minutes. So again, we have a lot of now portable devices that we can actually use nowadays. And I think it's about time for us to add insonation into our physical examination. And probably it's also time for us to use, particularly in the COVID environment, more insonation rather than auscultation. Okay, my other half talk. Okay, so bear with me for a minute. Okay, so pneumothorax. So this is an interesting article. Basically, pneumothorax have been described, particularly in this current wave. I think a lot more people are experiencing or seeing more pneumothorax in COVID-19 patients. It is something that it's true even as evident from this particular article. There were about 16 centers, 160 odd patients. But the pneumothorax in COVID-19 can happen in spontaneously breathing patients as well as in ventilated patients, mechanically ventilated patients. But it does not kind of predict prognosis, meaning if the patient has a pneumothorax, does it mean that the prognosis is what? It's still unclear yet, probably not based on this particular article. So let's see how lung ultrasound can help with making a diagnosis. Again, as I pointed out, this is, okay, the important, when you have lung sliding, you can rule out pneumothorax because this is a sliding of the visceral on against the parietal pleura. And this absence can mean a possible pneumothorax. It does not mean that it's a pneumothorax because it is actually relative to the wall, and these are other causes of absence of lung sliding. Okay, it can be endobronchial intubation, atelectasis, pneumonia, ARDS, and so on and so forth. So it's not as simple as that. But if you have lung sliding, you can easily rule out. You can say that definitely the patient has got no pneumothorax, at least at the point where you put the probe on. Okay, but let's follow. This actually available. This algorithm is actually available in the WinFocus international recommendation. Let's go to lung sliding. As we agreed just now, this is lung sliding. Hope everybody agrees. When you have this, you have no pneumothorax. Okay, so when you have that, then we go, if there's no lung sliding, we go to the B lines. Agree that this is a B line. So this is a patient with florid B lines, so most likely a pulmonary edema kind of thing. And you cannot have it's basically how the image is generated. There cannot be a pneumothorax when there are B lines like this. Okay, similarly, if that is florid B lines, if this is just one particular B line, similarly, you cannot have a pneumothorax when you have B lines. So when you have B lines, definitely no pneumothorax. And then the next one step is lung point, as I highlighted in the last talk just now. So this is where when you put the probe, you will see this. This is something interesting because if you have something on top here, the entity may be called what we call radio occult pneumothorax, which may not be actually picked up by chest radiograph because it's a small pneumothorax, but it can definitely be picked up when you do lung ultrasound. So the bigger the pneumothorax is, the more posterior or the more dependent the location of the lung point. And then finally, lung pulse. So lung pulse, technically, this is actually near the precordium. So if you have a pneumothorax, so basically you have air between the visceral and parietal pleura, there cannot be any transmission of the cardiac pulsation to the anterior wall. So when you have this, when you can see cardiac pulsation on the chest or the pleural line, you can definitely safely rule out lung pulse. So this is just something interesting. Can you see this pulsation? This is actually a pulsation of an artery of the chest wall rather than actually pulsation of the cardiac pulsation, transmission of the cardiac pulsation to the anterior chest wall. Okay, just to sum up again, if you have lung sliding, no pneumothorax, B lines, no pneumothorax, lung point, yes, 100% pneumothorax, lung pulse, yes, no pneumothorax. But when you way down below, that's where the tricky bit is. When you have no, 2/3 of the time you may be dealing a pneumothorax, and 1/3 of the time you may not be dealing a pneumothorax. Okay, so let's just repeat again. Sign to rule out pneumothorax, sliding. We agreed that no sliding but B lines. Okay, no sliding but lung pulse. We rule out pneumothorax. Slidings that rule in pneumothorax, absence of sliding, B line, and pulse. But to be confident, you need to look at lung point. This is where you can be really confident that the patient is having a pneumothorax. Okay, just some take-home message. Air in the pleural ultrasound cannot be ultrasounded, but lung ultrasound is sensitive to the fact. 3 signs: lung sliding, B lines, lung pulse. Okay, rule out pneumothorax. The only thing that has high predictive value power is lung point. And we need to look from the anterior to the inferior bilaterally. And it's actually been proven that it is actually more sensitive than chest X-ray for diagnosis of pneumothorax and similar high specificity. Thank you very much.
Regarding the lung ultrasound, one of our participants actually asked how to estimate the amount of pleural effusion based on the measurement that we get from the lung ultrasound. Like, is there, like, if let's say we measure it's at 5 cm, can we roughly estimate around how much is the amount of pleural effusion in the lung?
There is actually some publication, but I can't recall it. Yes, it's actually the depth of the actual effusion. Usually, I mean, in my practice, of course, I don't calculate, but so when you put your ultrasound and you see one particular view. So usually in a transverse, in a longitudinal view, and then I will move up. So basically see where I can get lung. So if lung only comes in view after I've moved to the middle part of the thorax, I know that I'm dealing with a large effusion. So that will give me an idea, but I don't calculate as such. But if, let's say, I'm just putting my probe around that point where I can see the diaphragm, and and when I push up to capillate and the lung, then I will see sliding sign, and I know I'm not dealing with a large pleural effusion. So it's all a matter of where I don't objectively measure them, but I will estimate and look at where the lung sliding appears. So if the lung sliding does not appear until it's further up in the capillate area, then I know most likely I'm dealing with a large effusion.
Okay. Okay. Last question. I think one of our participants actually asked what are the features that we can diagnose, how we can diagnose PE from POCUS. I think the few features that we see on ultrasound.
So if we you talk about pulmonary embolism, so if it's a massive pulmonary embolism, lung ultrasound basically doesn't show anything much. Basically, if we are talking about COVID, with pre-existing COVID pneumonia ending up with pulmonary embolism, then it's going to be very difficult. But let's say, for example, a patient in the ward, TKR, lung is normal, suddenly collapse, and you want to make a diagnosis. So the lung profile should be an A profile, so a clear dry lung, and then you, if it's a massive, you want an echo, focus echo, demonstrating right ventricular strain. So that will definitely point out to a PE. Some would also suggest that you do compression sonography just to document that there is a DVT. So when there is a DVT or remnant of a DVT, that will also point out to, will kind of lend some support to the diagnosis. But if in the absence of compression sonography, it shouldn't rule out the possibility of PE. So in a massive collapse pulmonary embolism, lung signs are minimal or non-existent. It is more of the focus echo, the right ventricular strain, or the right heart strain to confirm the diagnosis. Of course, at this point in time, if you do have that, and then the question of whether you want to go all out with thrombolysis and so on and so forth, that's another question. But I think in COVID, probably with the resources that we have, we probably don't want to spend too much time, put it that way.
But then again, like in COVID, many a time we see a lot of patients who have just subsegmental or just segmental PE, right? In those cases, we won't really see the right heart strain, right? Unless it's a pulmonary embolism at the main pulmonary trunk.
You will see segmental. You will see segmental. In fact, if it's just a small, you will see areas which is segmental infarct. Then you will not. There's nothing. There's no strain to the right heart because of the fact these are quite small arteries that has been blocked off.
Okay. Thank you very much, Dr. Shahridan, for all the explanation. I think we'll move on to our next speaker.